So in our Giddens lecture on communication, we talked about the concept of communication. Now we're going to take a look at your Davis text and talk about the how. We know the why. Now we need to learn the how. How do we communicate effectively? And for this, we're going to be working out of our Davis chapter 21. Now, there are many factors that infect verbal communication: the vocabulary that's used, the type of meaning, the pacing of the conversation, the tone or pitch of one's voice, how brief or clear the communication is, the timing of the communication, how important or relevant is the information, how credible the receiver of the information sees the sender as, and sometimes humor could definitely impact how we communicate. Our nonverbal communication can be just as important as what we say with words. Nonverbal communication includes things like facial expression, the posture or the gait of one person. Their personal appearance can tell you a lot about their socioeconomic status, their culture, and their feelings. Gestures done with hands can emphasize and clarify spoken word, but can have different meanings to different people. And finally, touch. While touch is a component of nonverbal communication, it can also be misinterpreted. Now in this picture, you can see that the nurse's shoulders are facing towards the patient, indicating an open posture. The patient is smiling and they're making direct eye contact, and the nurse is using touch both on the shoulder and the hand to make a connection with the patient. So there's a lot of nonverbals you can get in communication. In this one, you can see the nurse is leaning in towards the patient with good eye contact. There's very close physical proximity. And again, there's that touch on the shoulder. Usually shoulder touch is very safe, well-received type of physical touch in most situations. Now there's different kinds of communication styles, from passive to aggressive to assertive. And the type of communication that we want you to do as nurses is assertive, where you're clear with the point that you need to make, that you're professional, and you let your point or your need be clearly known. So we want to use an assertive style of collaborative professional communication, and we use standard tools of communication like the SBAR we spoke of. I'd like you to take a minute to pause the video, open up your Davis Volume 1 to page 460, and read box 21-2, where it has the collaborative professional communication standards of professional performance from the ANA. Now, it may feel really intimidating to think about using assertive communication as a nursing student or as a new nurse, especially when you're dealing with physicians who have been in practice for the last 20 years, or a nurse who's been working for the last 30 years, or someone who looks at you sideways because you're the new person and they just don't know you yet. But asserting your opinion and standing up for your patients and calling out things that may seem unsafe are incredibly important to what we do to provide safe patient care. Let's take a look at what it might look like if you don't use assertive communication as a nurse or nursing student.
I was on a surgical team when I noticed a doctor making a critical error. He was preparing to operate on the wrong side of a patient. Now, we have a surgical safety checklist that we follow, and in this case, we noticed the permit didn't match what the doctor was doing. So we tried to stop the surgeon, but he said the permit was wrong, even though it had been verified by the now sleeping patient. We couldn't even get support from the supervisor or the anesthesiologist. So in the end, the surgery went forward. As nurses, we felt awful because there was no support from management to stop this doctor. I mean, what's the point of having a checklist when it's not even followed? We felt absolutely powerless to be an advocate for this patient.
So remaining silent or scared to speak up is more than just being a quiet person. It fails to advocate for our patients and their safety. So let's give you a couple tools on how you provide assertive communication. Speak clearly and positively. Be professional in the way you speak. Use I statements. I'm concerned about the patient because. Focus on the issue. Use effective nonverbal communication. Don't invite negative responses. Unfortunately, sometimes there's bullies in healthcare, and we need to not let them win. Other things like operating on the wrong side of a patient can happen. Accept criticism and be willing to grow. And strive for a compromise whenever possible. So how do we collaborate with the healthcare team in communication? We use the SBAR, or in this case, SBAR-Q. Situation, what's going on with the patient? Background, what's their medical history, or what kind of treatment have they had up to this point? Assessment, what's their current physical assessment? What are their current vitals? What's their affect and mood? Recommendation, what's next for them? What do you need the healthcare provider to do? And then giving a chance for the return of feedback by having the receiver of those questions, of the SBAR, ask questions back to the sender of that message. The second thing we do is patient rounds. And so that's a time where the collaborative healthcare team can go and all talk together about a patient situation so that it's avoiding that telephone communication and getting everybody in the same page. So let's talk a little bit about therapeutic relationships in healthcare. The purpose is to focus on improving the health of the client and making our care about them, making it patient-centered. It's a way that we can provide necessary information about their health, their treatments, and their care. And therapeutic relationships are going to involve the use of therapeutic communication. So what is therapeutic communication? It's client-centered, patient-centered. It's goal-directed, focused on their health and well-being and the goals that they're accomplishing. And its purpose is to also strengthen the therapeutic relationship between the nurse and the patient so that they trust you and feel comfortable and competent in the care that you provide. So there's different phases of the therapeutic relationship. And the first phase is the pre-interaction phase, before you've met the patient and you might be looking through their chart or hearing information about them from your bedside or from your report from the previous shift. That's the pre-interaction phase. The second phase is the orientation phase, when you're first meeting the patient, doing the introductions, and establishing rapport and trust. Patients can learn a lot about us right from the beginning, and it's important that we give them a good impression that we're there to help them and that they can feel competent or comfortable with our competency and our ability to give them what they need. The working phase is when you're really in it with the patient and you might be giving them medications or doing their assessment or educating them about a new medication that they're going to be on. And we use the therapeutic communication techniques to make sure that we are able to accomplish our tasks in a way that is client-centric. And the client's able to clarify feelings and concerns through the verbal and nonverbal communication, and that we are picking up on those things. And this working phase is an active part of building that therapeutic relationship with the patient. And finally is the termination phase. So patients being discharged from the hospital, or you're sending them to surgery and you are the preoperative nurse, that ends your relationship with the patient and you send them off into the care of the next healthcare provider or into the care of their loved ones. So some key characteristics of therapeutic communication are empathy, really understanding where a patient's coming from, providing respect, being genuine. Patients can see right through us if we're fakers, but genuine care and concern for a patient is very evident to them. Being very specific and concrete in what you're doing with them. And being willing to confront the patient if you don't think that they're being forthcoming with you, or you're misunderstanding or not quite understanding where they're coming from. So confronting them and asking to make sure that you can get on the same page. So how can we enhance communication with our patients? First, address them, greet them, use their name, ask them what they want to be called and what their pronouns are. Listen actively. I remember a triage nurse in the ER whose computer was over here and you're the patient, and they would just say, okay, why are you here today? Okay, how long has that been going on for? Do you have any allergies? Any medical history? Okay, here's your allergy band. Go ahead and have a seat in the waiting room. I'll call you when you're ready. And rarely engaging with the patient. So we need to actively listen to our patients and provide those nonverbals that tell them that we're present, we're there for them, and when we're with them, that they're the most important person in the room to us. We need to establish trust, be assertive and clear in our expectations, and interpret body language and share observations. So if you see a patient crying or looking down, you can say, I see that you're crying. How are you doing today? Tell me about that. Recognizing some of those nonverbals, acknowledging them, and giving the patient time to share them if they want to. Explore issues. So if a patient says, oh, I'm really sad because my daughter didn't come to visit today, exploring issues would say, tell me more about that. And using open-ended questions to really allow them to go further into those feelings or those thoughts. Using silence. Sometimes we can get uncomfortable with silence, can't we? But silence those pauses can allow them to reflect, think, and maybe share more before we interrupt. Summarize the conversation. By doing so, it makes sure that you received the message appropriately, that you understood what they said, and it also tells them that you were listening. Process recordings are a way to write down a communication that we had with the patient, reflect on the types of communication skills that we used and how effective they were. Now, while we don't have a specific clinical for 107, I would encourage you as you go into your 108 clinicals to do a process recording. Go and have a conversation with your patient and then write down your part of the script, what your patient said, and what communication skills you used and how effective they were. By reflecting on your use of therapeutic communication, you'll get better at it. Now, some of these things I've kind of glanced over pretty quickly, and I would encourage you to go back to this enhanced therapeutic communication components in your Davis from 462 to 465, and really take some time to understand fully what these communication techniques are. So there are some barriers to therapeutic communication. Asking too many questions. We're not reporters, right? Fire hosing information, just dumping information. If you think of fire hoses are really, really big, right? And so you can just dump information at a patient and it may be more than they can take in. Asking why. The question why can seem rather judgmental. Changing the subject inappropriately. Maybe the patient's brought something up that you're uncomfortable with. Changing the subject on them when they're in the middle of a thought is not therapeutic. We want to follow our patient's lead. Failing to probe. We do want to ask those open-ended, tell me more about that. How does that make you feel? Expressing approval or disapproval. We're not here to be a judge or a jury. We're just there to listen. And offering advice can be a barrier to therapeutic communication. We're there to support their thinking and their thought process, not provide our own advice into what's going on. Providing false assurance. A patient who has a prognosis that they have 5 months to live, they might not want to hear that everything's going to be fine. Sometimes we don't want to give false hope. Stereotyping. We don't want to assume someone feels a certain way just because they look like they're from a certain culture or a certain gender. Using patronizing language. Avoid words like honey or sweetie. No one wants that. That's called ageism, right? When we are looking down on someone based on their age. Be sensitive to cultural differences as it comes to communication. And make sure that they're culturally appropriate for the individual. Address language barriers. And if needed, make sure there's a medical interpreter that's being used for the patient. We don't want to use family members for medical terminology. We want to make sure we're using certified medical interpreters that are employed or contracted by the healthcare facility. So someone with impaired speech may have a difficulty with verbal communication. And you might use things like hand gestures or sometimes even whiteboards. You might use family assistants to ask them how they best communicate. Be positive and be patient. And remember, we care for the patient no matter what their ailments are or their difficulties. So someone with impaired cognition, someone who has some mental delay, developmental delay, make sure you're communicating with them. We don't want to ignore the patient and just talk to caregivers. We address the patient themselves. Don't rush. Sometimes it may take longer, and that can be frustrating when you've got a long list of tasks, but we need to be patient with the patient. Eliminate distractions. Use short sentences and ask simple yes and no questions. I hope this lecture gave you some practical tips and tools to improve your communication. It's not something we're going to get right on day one, but we need to seek to grow in our abilities and skills with communication, both interprofessional and therapeutic with our patients, and reflect on our communication and commit to growing into that.